Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm joined by Dr. Katie Mess and Chris Kelly and Chris Barker, who are both Physician Associates. Chris and Chris have both been on the podcast before. You might remember them from the Obs and Gynae episode that we did last year. I thought it would be great to get you both on today and with Dr. Katie to talk about the project that was started when you were both students, Chris and Chris, student Physician Associates, in the midst of the first wave of COVID and the first lockdown, and the way in which the university responded to help get you into the hospital as student workers so that you could support on the front line. If it's all right, I'll start with you first, Dr. Katie, because you were sort of spearheading a lot of this project, weren't you? And it was from reading your paper that I found out about the projects that you'd done and this brilliant way that you'd enabled Physician Associate students to contribute to care during the beginning of the pandemic. Do you want to start first by just sort of explaining the paper and the project itself?
So the paper was really based around a model that we used during COVID-19 first peak of the pandemic. And it was something that kind of an idea that came up overnight with the news of the pandemic, but it was something that we learned a lot from over the whole period. We felt it was quite important to put out there as a paper because it was a model that worked really successfully for us. And obviously we didn't really know what was going to happen with the pandemic at that point if we take ourselves back to when it was published. It's funny looking back on it now because it's been a good year or two really since we did it. But at the time it was we learned a lot from it basically. So we thought it would be worth publishing. So basically, it's a model that we used during the pandemic. We started by introducing what we call student clinical assistants to our trust at the Norfolk and Norwich Hospital. And that came about because of an overnight change, really, where teaching for UEA students was cancelled, specifically clinical placements, which is the area that I was working in. And because that kind of went away overnight because of the risk involved with COVID that was coming out, we were left in a situation where there was a lot of students with a lot of anxiety, didn't know what was going to happen with their clinical placements. And you can imagine a big hole really in their teaching as well, which was an important thing that we wanted to pick up on. But also on the flip side of that, a lot of workers overnight, as we all know, they weren't able to work anymore because they were having to self-isolate, quarantine, exactly all those things because of their risk of COVID. So that really was leaving all the teams in hospital in a really difficult situation. So Professor Barker, who was in charge of the project, came up with the idea of creating a role for students to work or help within the hospital, to try and fill in some of those gaps and just get through as a trust as we could at the time.
So this was for medical students as well as physician associate students?
It was. So we started with fifth year medical students, and the reason for that was because they were at the end of their training and they were about to do their final year exams and everything changed for them overnight. And the end of their fifth year training anyway is a clinical type placement where they go out into the workforce to learn the job. So that was going to be a big chunk of their final year training that they were going to miss. So we thought we could utilise the students really and use a similar role for them. They were kind of ready for that. They're just about to qualify as doctors to go and help the teams as well. So they were the first ones that we put out there, and we had such an overwhelming response from everybody, the students, the clinical teams at the hospital, that they were a really good resource to have there, filling in gaps, like I said, where people were not there, off sick, or again, because that was evolving every day, people were having to isolate and teams were changing every day. They became another member of the team that could help, even if they weren't able to do certain things like prescribing, etc. They were just a good person to have around as part of the team. So we then looked at what else can we do? And it was really an outcry from other students, I'd say, that we thought, let's expand this even further as well to other medical students and the physician associate students as well.
Were these roles paid for?
Yeah, so we were really lucky because that was another really integral part of the model working so well, I'd say, for us at the Norfolk and Norwich, was that medical staffing as well as the medical director, Erica Denton at the hospital, was really behind us kind of doing this role. And we were able to work with the medical staffing team to implement contracts really quickly, within a matter of days, to be honest, which we know from experience, medical kind of introducing or starting a new role with a contract can take a little while with all of the checks that have to go through. But because of the need for the trust, then kind of the checks were done in at the same time as when people started. We kind of had to think about where we would put people in terms of how much they'd get paid, which is another important thing, because we wanted people to be paid for the time they were giving. Although an interesting part of a survey that we did towards the end, which I'll hopefully talk a little bit more about, a lot of people went into the role not necessarily wanting to be paid. It was a big thing that they said, that they just wanted to help really in that situation, which I think was how everyone felt at that time in the country. But it was important to us that people did get some reward, or not reward, but did get paid for the work that they were putting into the trust as well.
Brilliant. I suppose at that time, there was a lot of unknown about what the pandemic was going to mean for the clinical workforce, for the patients, for the level of demands that we were going to go through. What did you see the major risks were, and how did you sort of mitigate those problems?
So it was obviously a really huge risk of contracting COVID for everybody, all the students that we kind of, I felt very motherly in the role that I took on. I didn't want anyone to go into the workplace without wanting to, first of all. That's why everything was a voluntary basis, and we made that very clear from the start. And it was something that, although it was a contract, it was a bank contract, so you didn't have to continue if, for example, you did a shift and you didn't feel it was for you, which a few of the students did, and that's completely understandable, because as the pandemic evolved, things changed as well. Even things like organising the training and the recruitment for the roles, we had to take that in consideration. We tried to create bubbles when we did the training for them, so limiting things to a group of 10 when we did the training as much as we could. So we tried to stagger everyone, although we were getting a lot of people through the recruitment process at the start of the training. We still tried to do that with social distancing and all of the measures that were coming into practice at that time. So we always did that, and we had to make sure that all of the students that were going out there were fit tested. We needed to make sure that they had the right equipment that was required at that time, and that they felt safe as well. We kind of also took on the role of pastoral care, and I felt that's what I also did along the way, and a lot of the administration staff as well. But the clinical skills resource area took on that role too. So if people were having any problems along the way, they could come to us. So there's that side of the risk involved too. And on top of that, we know we had at least one student that contracted COVID during the time that they were working. However, a lot of the students went out into the workforce before swabbing was even a thing, to be honest. So the number was probably slightly higher than that, and we just didn't have the swab test confirmed prior to that. A lot of people had to isolate in the time, and again, our role as the team that was overseeing the whole project was to orchestrate all of that, make sure people were isolating when they needed to. We knew that they were okay, really, was the other thing too.
So Chris, at the time you were PA students when this was being brought through. So you were some of the first, I guess, to take up the offer to go into the hospital and work as a student. What are your memories of that time?
So I remember at the time it was really quite strange, because obviously it's March, it was kind of just started our second year of quite an intensive course, and then suddenly our placement got cancelled and everything got cancelled for the foreseeable future with our learning. So it's like, what are we going to do? We didn't even know if we'd qualify that year or anything. So it felt like something, like for me, it was just something to do. We can do it. We can help. And, it was daunting, but a little bit exciting to kind of help out and be there, as weird as that sounds. But it meant that we had something to do, because at that time, everything had just stopped for us.
Yeah. So I would very much agree with what Chris said. It was quite exciting to have gone from quite a daunting prospect of everything being cancelled to then having something that we could at least latch onto and get some of that experience back and give something back and feel like we were at least progressing in some way, even if it wasn't in a sort of traditional way. So I remember a lot of that feeling.
Day to day, what work were you doing on the wards?
So most of the shifts I did over that period were assisting on critical care and HDU, and most of it was kind of just supporting the nursing staff with their jobs, because they were busy and they were stressed and they were short-staffed as well. So it's helping them with their PPE donning and doffing and things, helping restock the PPE and other things. A few shifts I was actually helping, assigned to a critical care nurse and help them running the ABGs and helping wash patients, turning patients, proning ventilated patients as well. So it's really what was needed at the time, holding hands and things like that.
Yeah, for me, I started a little bit later than Chris, and then I moved on to a lot of the swabbing and manning a lot of the swabbing stuff. That was quite interesting because it was all very new, so there's a lot of learning involved in not only how to actually swab someone appropriately for COVID, but also just how to run these sites, which was quite interesting.
Thanks, Chris and Chris. Really interesting to hear what you were doing. And I think
so we deployed students to wards to start off with, but the outcry for help on our critical care complex was becoming was an increasing need for that. Our hospital, the Norfolk and Norwich, became a surge centre for the local area, so we were taking more COVID patients as well, especially ones that needed critical care admission. So the initial training that we did was for general ward help to assist the ward teams, but later on, so around the start of April time, we introduced extra training for students who wanted to go and work on critical care to help the teams there. And that included kind of orientation to critical care, donning and doffing, as Chris have mentioned, helping with that, as well as things like proning patients, which need a lot of manpower to do that for COVID patients. So that was a really useful role, and a lot of the students that we recruited at the later dates went straight into those roles of critical care, which was really helpful. And then later on, as well as all those things, we helped with the swabbing teams as well, as Chris has mentioned, as that became much more of a government initiative to set up swabbing centres. Lots of students were trained to do the swabs and sent out to sites to help run them and facilitate them as well, which was a very interesting process too, as well as even working in labs with the virology team too, so testing samples. So there was lots of different areas where the students became a really integral part of many teams. As well as that, they also went out to help with some of the COVID administration side of the trust too. So there was a dedicated COVID team, and we allocated some students to go and help with that as well.
What feedback did you guys get on the ward from the people that you were working with and the patients you were caring for?
I think particularly on critical care, having people there to help don and doff did make a difference. And we were also, there were a few shifts where we kind of just manned the donning station, and we were able to also kind of make cups of tea for the nurses on their break, and the little bits of support that are like quite important. Everyone was busy and stressed, but I think we were useful.
Yeah, I never had any negative feedback. I had a lot of people asking what we were doing, and when I explained it, a lot of people were really appreciative that we sort of agreed to help out in what was obviously a very challenging time for everybody.
And Katie, what was the feedback you were getting?
So we collected feedback in a multitude of different ways, really. So ad hoc, obviously, from students. That was one of the beauties of the model we used. I think that we had a dedicated team that were overseeing the students that were sent out. So that consisted of myself as well as the other clinical fellows that were working at the time. We had feedback that was coming in from their side, so higher up within the hospital, as well as feedback from clinical leads in all departments. I would be in regular contact with them, so emailing, saying, how is it working? How's the number of students on the wards, for example? Is this something that we need to change? And that was a weekly basis thing, really. So it's continually evolving, which I think is why it worked quite well. So although quite time consuming, and it was definitely a full-time role for us all, I think that allowed us to kind of work as the pandemic changed and really utilize students as well as we could. So one of the things we did do was change the amounts of students that were working on night shifts. So again, that was an optional thing. If people wanted to do night shifts, they could. But we also made sure when things like lectures restarted that everybody was not working too much, having enough time to do studies in the time allocated as well. Towards the end of the project, as numbers of COVID-19 were reducing, we also took decisions to pull students back and stop some roles in certain areas, again, just based on what was happening. And when that happened, we did evaluation for certain number of the students. A big thing that changed in the time is that the government introduced the FIY1 roles, which is the interim FY1 roles. So a lot of our year 5 students, about 50% or so, took on those roles. So we lost a lot of student numbers that way. But that also meant that we could recruit more of the lower year students as well, for example, some of the other PA students. But that's when we did the evaluation too. So that was just a general questionnaire and feedback from students, and it was overwhelmingly really positive as well. They felt they were really well supported. They didn't feel pressured to take on tasks, and they were satisfied with how they were being paid as well. And some really important questions we asked within that is that they also, how did they feel that the role helped with their training? Because we needed to remember that obviously where they were at, and as Chris and Chris have mentioned, the role was also to try and help in a way for clinical opportunities and experience. So that was another aspect of the evaluation that we asked, and things like, did they feel more confident to go into their next year of training? They felt they'd learnt new things as well that they weren't previously taught in their lessons, and they believed they were helpful as well to the teams, which were really important aspects. So overwhelmingly positive from all angles is how I'd summarise.
Brilliant, thank you. I suppose the obvious question that's come up into my mind is, given what we've learned from doing it, how are we going to use that knowledge in the future? Is there scope to do something differently to improve things like this in the future?
I think at the time of writing the paper, so I'll take myself back to how we were thinking then, is that we didn't know, we still don't know what's going to happen with COVID and the pandemic, as things are coming to light even more now with different variants, but even more so back at that time a couple of years ago. We got over that first wave and we were relieved really, but we all were very wary that it could come back, as we know it did. I think us putting that model out there was really just to highlight the use of students more than anything, and that they can be really useful in these roles. And I know a lot of hospitals did use all different types of students as well. And the difference with, we think, our model that we use is that we recruited people so quickly and managed to get them out into the workforce within a space of 10 days or so, which I think was a really good model to use, especially with the unpredictability of COVID. If that happened again, just knowing that that could be done and it was successful was a really important thing. As I've mentioned, the medical students in their 5th year have that kind of clinical placement that's much more focused on learning the job as opposed to learning practical skills and theory, etc. And again, something that we asked in the evaluation was, or the feedback that we got from students was that they really wanted even more of that in earlier years. So the 4th years that completed the 4th year medical students, that completed the evaluation said they'd find it really helpful to have more kind of clinical team-based opportunities if they can. Obviously, we know now that's become even harder because clinical placements are still evolving with COVID and having to rearrange multiple courses and teaching sessions to fit with all the new guidance with class sizes and things like that. But I think it's another bit of evidence that students really like being on clinical placement, and the teams also find it really helpful too.
Brilliant, thank you. Chris and Katie, thank you so much for joining me on the podcast. It's really interesting to hear about what you were doing as a response to the COVID pandemic. If people want to find out more about what you did and what happened, I'll leave a link to the paper in the show notes so people will be able to find it on their device below. And if they've got questions, would you be happy for them to get in touch with you?
Definitely, yes.
Perfect. I'll leave your contact details in the show notes as well. Thanks so much for joining me. And thanks to you for listening as well. I hope you found that really useful to find out a bit more about how PAs were able to be deployed in helping the response to the COVID pandemic.
If you'd like to get in touch with me, I'm on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.